Okay, everybody, I'm gonna start. So just to say, my name's Chris Jeffries. I'm the Workforce Programme Director for the Northwest. Welcome you to this webinar on Education and Training Operating Model, from Design to Delivery, an update on where we are. Just to say a little bit about WebEx, for those of you who maybe haven't used it. Hopefully what you can see in front of you is a slide, and then down the right-hand side you can see a list of names of the people who've dialed in, and then there's a box towards the bottom called chat. So if you want to send an email to everybody, you've got everyone in the send to box, and you type in the box below and then go send. Or if you want to email somebody else who you know is on the call, you'll find there are a list of those people below the everyone part. And it sounds like everybody's reasonably quiet, but if you end up with lots of external noise, it'd be really helpful if you could use the mute button, which you'll see is like the old-fashioned microphone stand. If you click on that, it'll mute you. Okay, so let's start. So this presentation really takes us through from the issue of the guidance, which came out on the 10th of January, and this guidance has been coming a long time. The original consultation actually started in December 2010. Then we had the end of that consultation at the end of March. We had the first listening exercise from the Future Forum, and then the government's response to that in June. And then in August we had the second education and training theme from the Future Forum, and that reported formally on the 10th of January at the point at which the guidance was issued. And this is now the definitive guidance, so this is what we're going to be working on for the future. There may be some slight alterations, because you may be aware the Health Select Committee is doing a review of education and training, and they may come up with some different recommendations, but the government didn't want it to hold things up, so we are just trying to run with this guidance. I should also say that almost everything in this guidance is possible without the requirements of the Health and Social Care Bill. So it's something which could take place regardless of where the bill gets to. So just to take you very briefly through the overall system, and you may not be able to read all of the words down the right-hand side, but the Secretary of State will have ultimate responsibility for ensuring that there is a commissioned health education system. In turn, that is undertaken through the Department of Health, and they commission through an annual agreement for Health Education England to undertake that. Health Education England will work with, but not be accountable to, Public Health England and the NHS Commissioning Board. So the line of accountability is direct to the department. Health Education England will then in turn pass on a lot of those responsibilities in a way in which I'll come to later on to local education and training boards, and that is the phrase we're going to be using from now on. It's not something we particularly like as a phrase, so the NOIC for that is LETBIS. So that's the phrase that we'll continue to use. And the LETBIS are primarily made up of, and I'll come to a lot more detail on this, health service providers. So it's very much the employers in the driving seat. But LETBIS will also link with higher education and other parts of education, and will also link with research, and in particular the Innovation White Paper and academic health science networks. So a key part of all these changes is that instead of us being measured by inputs of education, the intention is that LETBIS will be judged according to the Education Outcomes Framework. And this is still a piece of work that is being developed, and in fact we're just about to write out to invite people to a workshop on the Education Outcomes Framework for the north of England. But you have these 5 main headings, and then below those there will be much more specific indicators which will back those up. And a particularly important one that's been reflected locally is the one about NHS values and behaviours, and ensuring our staff have the right attitudes and approaches towards patients. So again, an overall outcomes framework rather than a sort of an input-based, target-based approach to it. Health Education England will host the LETBIS. That is, the LEPBIs will be part of Health Education England and will be and each of them will be a formal decision-making board accountable to Health Education England, but very much autonomous, very much able to make their own decisions about a variety of things which will be delegated down to them. And the whole of the flavour from design to delivery is very much focusing on that sense that LEPBIs are independent, that they can undertake and make decisions on their own behalf within the overall framework. Membership of LEPBIs needs to come from the full range of healthcare and public health providers, so all types of different healthcare providers. They will have an independent chair, and they also need to have local advisory arrangements to reflect all the different interests and stakeholders associated with clinicians and professions and a number of the other stakeholders that we engage with for workforce and education. And in fact, again, as I'll come to later on, we already have a lot of that in place. Our local network leadership groups do have a full membership from a variety of different healthcare providers, including public health, and we do have the stakeholder forum, which reflects a lot of the local advisory arrangements. We don't quite yet have the independent chair, but we'll be working on that over the coming year. So again, a bit about the overall structure about how this will work, and particularly the accountability for quality of education. So Health Education England will have a chief executive. It will be a special health authority, and I've got a slide which talks about the timescale for that later on. And the only named director at the moment, although the directorate structure for Health Education England is due to be issued shortly, the only other named director is a Director of Education and Quality. So the LEPBIs will then have overall responsibility for things locally, and they'll be run by a managing director. Obviously, it can't be a chief exec because it's within Health Education England. And in turn, there will also be a local Director of Education and Quality. And it's intended that they should at least have some very strong links, and it suggests an honorary contract with the local university. So the LEPBI will also be accountable through to professional regulators such as GMC and NMC and so on. And the Director of Education and Quality locally will also have a dotted line of accountability in terms of professional accountability to the Health Education England Director. Funding, a lot of the changes around funding, and the main changes are we've been talking about moving to having an education tariff, a tariff for people providing education within trusts, and this has sometimes been called in the past the MPET review. So it is intended that we will implement that. So we will have an education tariff for students for clinical placements and for postgraduate medical training, and that will start in April 2013. And they will be national tariffs, fixed, at least initially, based upon the pilot work that's been undertaken. And it's intended as well, or we haven't quite got the development of this yet finished, that some of that may be in the same way as we have Sequin for payment by results, then some of it may be about quality outcomes. That won't be all of the money that goes through MPET. We've obviously got all the amounts that go through to higher education for bursaries and so on. And there will be flexibility at the margins for things which are deemed to be non-core functions. Now, some of that we think is things like HR strategy, but also ensuring that CPD continues and also activities for bands 1 to 4 and apprenticeships for the wider workforce. So we think, again, that there still will remain the scope for MPET to be able to undertake all of those activities. And that is a change from the original consultation, which was going to limit the scope. So we're pleased because we think that reflects what locally what people wanted. So Health Education England, Special Health Authority from October 2012, accountable to the Secretary of State. It may, in the longer term, become a non-departmental public body, but that's sort of for several years' time. So the main purpose up there is ensuring the health workforce has the right skills, behaviours and training and so on, and in the right numbers to support delivery of excellent healthcare and health improvement. 4 main functions. The national leadership on planning is about effectively having a national workforce plan, particularly for those professions or subspecialties where it needs to be considered at a national level. That's not to say there'll be a full national plan for local nurse commissionings, nurse commissions. It's more that they'll provide the overall framework for that. The second function is around actually developing the LEPBs and supporting them, and then of course holding them to be up to account. So there will be an authorisation process for LEPBs over the coming year. The third is that Health Education England will hold the ring around the quality of education and training. So they'll set the overall framework to ensure that regulator standards are complied with. And the fourth area is that they'll allocate all the money out to the LEPBs. And Health Education England is in the process of developing an allocation policy to undertake that. So a lot about delivering against the overall education outcomes framework and doing those kind of activities. And we have a number of colleagues across the Northwest who are very involved in Health Education England. Joe Rafferty, who's our Associate Director of HR Strategy, is the Transition Director of HR, and I'm the Transition Director of Finance for Health Education England. So a very big advisory structure as well, so building on a lot of the work that's already been undertaken. So professional bodies, there will be a professional advisory board for each of the professions, with some, I have to say, grouped together. So this is very much mirroring what's happened up to date with Medical Education England. So there'll be a medical board, a nursing one for allied health professionals, healthcare scientists, dentists, pharmacists, and so on and so forth. Secondly, there will be a strategic advisory forum, which is to pull in all the other stakeholders, including the Department of Health, Monitor, Skills for Health, and so on, HEFCE, BIS, and all the other major stakeholders who have an influence around Health Education England. And that also includes the other principalities, because of course HEE is just about England, but a lot of education issues do go across the whole of the United Kingdom. The bottom left-hand quadrant about HEE LEPB partnership group, there's already a lot of joint work that takes place between the current SHAs and the Department of Health, and it's intended that that should be replicated going forward, so that a lot of the work that HEE does is informed by what the local LEPBs want to do and using their particular expertise. And finally, a lot of work around patients and public forum and the way in which they can be engaged in Health Education England's work. And that's partly through use of lay members and some of the patient groups, but also through other processes that we'll be designing. So local education and training boards' main purpose is to lead workforce planning and education commissioning, so very much the functions that local SHAs currently have within a geographically defined area, making sure we've got enough people there and that they're the right sort of people, as well as supporting the national priorities. And the 5 core functions there are ensuring security of supply, so again making sure we've got the right numbers of people, undertaking the detailed local workforce planning and local priorities, holding and allocating the money on behalf of Health Education England for the provision, so all the contracts and so on that we currently have, and the learning and development agreements, actually commissioning education and training both from the universities but also from our provider organisations in terms of placement, making sure we've got good local partnerships with clinicians, local authorities of course because of the public health workforce, health and wellbeing boards, universities and all the other providers of education that we have, and particularly the guidance makes a particular play on this, and making sure we have good links with education and research, and strong links with the academic health science network when they emerge. And finally, other things which we are allowed to do within the flexibilities. So that's workforce benchmarking. So that's a kind of reference that we managed to get in there to make sure that we can carry on doing EWIN, but also leadership and OD. And as I said, some of the things like HR strategy and so on. So just to say that we do have a lot of the work that goes on now within the SHA is expected to transfer into the local LEPBs. Staff will obviously transfer across to Health Education England, but we'll be working at the local level. So all LEPB staff will be hosted by Health Education England, but it will be up to the local LEPB board to determine the executive structure and also the size and scale of the operational teams to be directly employed by HEE. and we will have to manage the same level of management cost reductions, running cost reductions, as SHAs and PCTs are currently going through. So the guidance talks about a one-third reduction between our 10-11 baseline and where we are in 14-15. We've been looking at the detail of that at the moment on a national basis, and we're thinking about having a cap, so a percentage of MPET that will be available to be used for running costs locally. And in fact, the Northwest is actually quite close to what may be the proposed cap for that. So I'm aware that you're not going to see all the detail of this, so I'll talk you through the overall workforce planning process and also draw out a bit about where that's particularly different. So we start at the top, darkish green box, with the Commissioning Board and Public Health England setting out their own sort of service priorities through the operating framework, much as we have at the moment from the Department of Health. In turn, providers then produce, based upon those service plans and those commissioning intentions, produce workforce plans, and they ensure obviously locally that those workforce plans reflect professional input to make sure that patient safety isn't compromised. The LETBIs will then collate and pull together those workforce plans and to produce effectively a local overall workforce plan, and then that goes off to the Centre for Workforce Intelligence, the sort of brownish box near the bottom. The Centre for Workforce Intelligence will again collate and analyse out and effectively act as a bit of a validation of what the LETBIs have been producing, and to make sure that some of the national issues are also picked up, because some professions are obviously they're very, very small numbers and sometimes can be missed or lost within that. The Centre for Workforce Intelligence then provides that as advice through to Health Education England, who assess and effectively produce an overall strategic operating framework for education and for workforce, which effectively is the National Education Commissioning Plan, the National Workforce Plan. And in turn, they then ask the LETBIs then to commission the local education and training, which then reflects that National Workforce Plan, and of course has reflected the local workforce plans as well. And then the providers provide clinical placements, as do the educational institutions in terms of pre-registration and so on. And we go around the circle. Now, a lot of that, again, is very much what we do at the moment, except that that the parts with the Centre for Workforce Intelligence, that sort of checking is really done at national level by the Department of Health, and we still don't, at the moment, produce an overall national commissioning plan. So those are sort of extra steps in the process, and ones which we think will actually help to deal with some of the issues which we're sort of grappling with, particularly with small professions. So the timeline for transition is Health Education England is going to be developing, and the transition team, as I said, is in place at the moment, ready to sort of develop up to October 2012, when it will go live as a special health authority. There's also, within that, Health Education England will then have shadow running for those 6 months. The LETBIs will be being developed, and they will start as formal subcommittees of the SHAs in April, and I'll deal with how we're going to deal with that locally in a minute. LETBIs will then go through an authorisation process through October, and then again we'll go live as part of Health Education England from April 2013. And what we've been trying to do over the last few months with the network leadership groups is ensure that we effectively have mirrored what we expect to happen going forward. So we've tried to set it up that a lot of the work and activity is very much how some of this will work as we become formal LETBIs. So a bit about the impact on the current LETBI arrangements. In the Northwest at the moment, we've got one programme board which has kind of just been focused on overseeing the transition, and then we've got 3 network leadership groups, Cheshire and Merseyside, Cumbria and Lancashire, and Greater Manchester. And we've gone through the formal consultation around those, but also around the process for that, for people being elected to those groups. And so we now have full membership of those groups. Each group has now met 4 times and has a programme of work going forward for the rest of the year. And what we're doing at the moment is discussing with the SHA cluster and the DH about how many LEPs we ought to have within the North West, and therefore how many subcommittees of the SHA we're likely to have, and how that's likely to go forward. And at the moment, the proposal which we're debating, and we've had some discussion about it with each of the NLGs, haven't got to consensus yet, but we're still moving along, is that we would have one North West LEP, but it in turn would delegate down to the network leadership groups for most of its activities. But we need to make sure that that's right, and that a lot of the concerns or issues that people might have with that are dealt with. So that's not necessarily going to be the final outcome of where we get to. But we do expect that discussion to take place over the next month and a half and so on. So that was all I really wanted to cover. I'm very happy to take any questions, either through the chat line or by people saying that they'd like to say something now. So kind of over to you for the next 8 minutes. Or not, if nobody's got any questions.
Hi, it's Tony Crick here from Morecambe Bay. You mentioned quite earlier on about the developing healthcare science board networks.
Yeah.
Can you tell me how you envisage that they're going to be integrated into this process?
Sure. Well, first of all, at national level, one of the professional advisory boards will be the one for healthcare science. At local level, what we expect is that the healthcare science network that we have in place will formally advise the network leadership groups. So what we've talked about with all the local professional advisory groups is that each of them will be able to provide formal advice to the network leadership groups about their particular aspects. And each of the professions is also represented through part of the membership. So nursing is obviously represented by the directors of nursing on the group, and likewise the directors of nursing represent the allied health professionals. It's intended that the healthcare scientists are represented by the medical directors who sit on the group, and we're going through a process at the moment of how we align the medical directors who are on the current network leadership groups with the healthcare science networks that we have across the Northwest.
What about the fact that Angela Douglas has just recently set up a lead scientist for each trust in the Northwest? Would that not be one of the posts?
Yes, and that's intended to be very much part of that link with the healthcare scientists networks.
Right. Okay, thank you.
Hello, it's Elaine Brealey.
Hi, Elaine.
Hi, you mentioned something in the MPET, about the MPET review, about some monies for development around the bands 1 to 4 and the apprenticeship. Who will have ownership of that, please, Chris?
Well, this is a really good example of how the stuff will work. So what we'll have is each of the LEPs, each of the NLGs will have a budget that at the moment will be a rollover of the current budget that we have for bands 1 to 4 and for apprenticeships. And what we'll do is pull together the workforce plans that are developed through the contracts we have with the Skills for Health Northwest Academy. And they'll come as proposals to the network leadership group to support. So the network leadership groups will effectively be asked, do you want to continue with this? Do you want to increase it, or do you want to decrease it? If you want to increase it, then where do we find money to support that, and so on. So the ownership will be with the people who currently undertake that, but will be formally approved by the network leadership groups through the detailed workforce plans that will come through.
Thank you.
I've got a question from Jean Rogers on the chat, talking about the PEF being funded, and they will be funded in exactly the same way, but instead of being funded by the SHA, they'll be funded by Health Education England through the LEPs. So there won't be any change to that funding, unless the LEPs actually say, we want to stop having the practice education facilitators. I don't think they're going to say that, but one of the things that we're into is a different form of accountability. It is that the network leadership groups need to set the priorities and need to say what they want to spend the money on, obviously within an overall framework. So I think one of the things that we have a lot of strength in is that we have a lot of infrastructure which is crucially part of what providers have at the moment, and practice education facilitators are a good example of that, as is the clinical placement network. And the proof is in the pudding. If you have people who are doing a good job within that, then the providers at LEPB level will then say, that's great, we don't want to lose that, we want to make sure we carry on with that. I've got another question on the chat line which asks about where does training for GP practices fit in with the LEPBs? And there's two parts to this. The first is actually training for GPs, and there's two subparts to that. There's training for the GP trainees, which will continue on through the deaneries, which in turn will be part of the LEPBs. There's training for community practice staff, and again, at the moment, we have some of that which goes through our CPD contracts and some through our community nursing contracts as well, and that would be expected to continue on. But one of the real challenges for us is to actually collect good workforce information from GP practices. And at the moment, we don't really do that. We use what have been the primary care trusts as our proxy for finding out information about that. But that's a fairly crude methodology. So what we want to do is really spend a lot of time working with primary care staff to do that. And each of the network leadership groups has two people representing primary care practices, and a lot of those have been either GPs, or in one instance we have a nurse partner as well. Any other questions?
No, thank you.
No, thank you.
Okay. Well, I hope you found that useful.
Can you send the slides out to the participants?
Yes, we'll ensure that the slides go out to the participants. In fact, I think we've already got them available on eWin. But yes, we'll make sure that you get the link for that. And please contact me if you want any further information about anything you've heard today. We will continue to communicate using this and lots of other means as well. Thank you very much indeed, everybody.